Hello, everyone. It is lovely to sort of see you here tonight, in the sense that I see a lot of really familiar names and some unfamiliar names as well. And so it's a pleasure to see everyone here. I'm glad you came to join me. I am Dr. Carrie Bedient of the Fertility Center of Las Vegas. And what we'll be talking about tonight is all of the answers around the COVID vaccine and fertility and how those things really play together. But first, like I said, my name is Dr. Carrie Bedient. I am one of three physicians here at the Fertility Center. And our center has really been a wonderful place to be in the sense that we're the longest standing fertility center in the city and have been around for over 30 years now. And that has provided a lot of opportunities, both in building the community that we're in, as well as having some really wonderful longtime employees who've been around for the bulk of those 30 years. We have quite a few people who've been around for 20 plus. And it gives us a lot of opportunities to do research. That's a really important thing for us here because when you're doing research, you are constantly thinking about what do we know? Do we really know that that's true or not? Or are we just making some assumptions? And how can we go about to make things better? And that's something that we pay quite a bit of attention to because you can't do research without watching the latest and greatest in all the journals and about actively thinking about what you're doing, even when you have been doing it for years upon years upon years upon end. We also do quite a bit of teaching here at the Fertility Center of Las Vegas, and we work with both residents and medical students. We have a relationship with the UNLV OBGYN residency program as their primary source for reproductive endocrinology and infertility education. I'm also the medical director, or the director of reproductive endocrinology and infertility for the Mountain View residency program. I'm the course director for the UNLV College of Medicine. So this is for the medical students. And we do quite a bit of teaching. And that's another way that we really appreciate, in addition to giving back to the students and the residents in the same way that our faculty coming up gave to us, it also means that we're paying attention and teaching and staying sharp because good students ask good questions and prompts a lot of, let's think about that. Let's look that up. Let's go back to the data. Let me draw this picture out for you so I can go from top to bottom and really explain it to you. And that carries over to how we talk with our patients as well, because the more educated patients are in knowing what they're going through, the better decisions they're able to make, the more they're able to participate in the process. And really, we all get the best success out of that. I have two lovely partners. I have Dr. Shapiro, who's the founder of the clinic. He graduated from Yale for his training. And he spent most of his training years there and then came to Las Vegas. He has founded not only the clinic, but has really done a lot of the basic research that has shaped much of what our field is today, particularly with respect to frozen embryo transfers and blastocyst transfers. I also have a partner by the name of Dr. Leah Kay, who is fabulous. She is coming to us from Yukon, and she's been here for several years now. And all three of us really work on seeing our local patients, working with egg donors, working with people who need gestational carriers, same-sex couples, the single people, egg preservation, cancer treatments, like the whole gamut of what you need to be a fully functioning fertility center. So that's a little bit about us, and hopefully we've had the time to get a couple more people logged on to listen. And what we're going to go through tonight is just step by step, what are the impacts of COVID on the body that we need to pay extra attention to? And then how does that interact with pregnancy? And what are the important things to take note of and to pay attention with that? We're going to talk about how the vaccines work and what their effectiveness is and how that impacts with someone who is trying to get pregnant or who's already pregnant. We'll talk about timing of the vaccine. And then at the very end, we'll talk about any questions and go through anything that I haven't touched on. So that said, COVID, coronavirus, eh, coronaviruses have been around for a really long time. The SARS epidemic that was in the early 2000s, MERS, there have been several epidemics throughout the course of even just the past 20 years. And what those epidemics are characterized by is really a very deadly disease that can be very contagious. And so when we look at coronavirus, one of the things that makes it such a difficult and scary virus to work with is that it's very effective at infecting people, and that the expression of what it does, meaning the symptoms that you get from it, are highly variable from person to person. So that is scary on the one side because of the effects that you see. I mean, all of us remember New York last spring and seeing all of the social media about Wuhan in China, about Italy and some of the cities really very devastatingly affected in those locations. And so one thing that's so concerning about coronavirus is how deadly it can be. And the other thing that's so concerning about it is how intensely quiet it can be, because you can have people who are affected by it, who carry the disease, who can pass it on to others, and they would never know about it. And so I see a lot of my patients have really cute masks that, in addition to say I'm smiling under this mask, I've got one patient who's got a mask that says "Save the Grannies," and that sentiment is part of the reason why everyone was so excited as soon as the coronavirus vaccine came into place, because there are so many people who are affected by it. And it's not just the grannies, it's really and truly everyone. um, COVID obviously affects the respiratory system and has a hugely negative impact. It's got an immunological impact as well, and it has impacts on blood clotting. And all of those things play a role. And one of the other really remarkable things about the coronavirus is that it doesn't necessarily distinguish between the old and the young when it hits. And one of the ways that this came home to me really very, very sharply is that I have a very medical family. Particularly all of my in-laws have are in the medical profession in one way or the other. And one of them had sent a set of totally de-identified pictures. So there's nothing in here that anyone can discern who the patient is. But a patient who was in her mid 30s, approximately 35 years old. She was healthy. She had no pre-existing conditions, no diabetes, no high blood pressure, no obesity, nothing like that. Her BMI was under 25, so considered to be in the normal weight range. And she was a runner. So not only was she just had general good health, she was actively working to improve it with being running a runner um, and having regular physical exercise. But she came to the hospital and was very sick. And when they did scans on her, they realized that her lungs were in far worse condition than anybody had ever really known. And what we see with that is the effects of her surgery that she ultimately had to have, because she needed a lung transplant. 35 years old, young, healthy, a runner, normal weight, no pre-existing conditions. This picture is picture of normal, healthy lungs. And this is her lung transplant of the new set of lungs she got. So you can see here, nice pink, filling up the lung cavity. There's ribs down here. You can kind of see the heart peeking out in here. This is a beautiful set of lungs. Now, when you look at the lungs that were taken out of her prior to her procedure, let me just switch over the screen. This is what we see. And so these are both of her lungs, and they're much smaller. They are fibrotic. You can see all these white areas. That's a lot of scarring that has happened. They're they're dark. The blood flow isn't good. I mean, these are lungs that you would expect to see in someone who's 80 years old, who's been smoking 2 packs a day for 60 years. And these were in a young, healthy woman. And so it's part of the reason why, even despite coronavirus being around for a year and all of us getting more used to the idea of it being around, it's part of the reason why it's really such a big deal. And it's such a big deal that there's a vaccine out, because this virus can affect people who are otherwise young, healthy, and good to go. So the next set of questions that we need to think about, we know, all right, this is why we should pay attention to it in otherwise young, healthy women, men, who are susceptible for getting the disease just because they have to go out into the world to conduct their daily lives. And when you look at pregnant women on top of that, and women who are trying to get pregnant, you have to consider a different physiology and how their bodies work than what you would in someone just walking around who is not trying to get pregnant or not actually pregnant. One of the obvious things about COVID is that it really takes a huge sledgehammer at the respiratory system. And pregnant women, just by virtue of being pregnant, already have quite a bit of strain on their respiratory and circulatory systems, because your total cardiac output, meaning all of the blood flow that is running around your body, has increased greatly just because you're pregnant. It's diverted in different ways. Much more of it is going to the uterus. It's part of the reason why pregnancy fog brain is real. And so your respiratory system is different, and it's almost compromised in a sense, because instead of having your full torso to expand and to move around, so if you're running or if you're taking really deep breaths for whatever reason, you've got expansion room. Your lungs can open up fully without any problems. When you have a pregnancy there, you have a giant watermelon in your belly that is not going anywhere. And so, as a result of that, your lungs just don't have the same expansion capacity. So that's why when you see pregnant ladies who are in their, deep into their second trimester, third trimester, they're more likely to be huffing and puffing a little bit, just because they don't have the same reserve capacity that that same woman did before she got pregnant, because she's got this huge watermelon in there taking up space. When you put COVID on top of that, with compromising the respiratory system and making it more difficult at baseline for air to move in and out, then on top of it, you've got that watermelon in there that prevents the lungs from physically opening up and taking advantage of lung tissue that is otherwise collapsed on itself because it doesn't have anywhere to go. You end up with double trouble. And one thing we see even with flu patients is that when a pregnant woman gets the flu, she gets much sicker than that same woman who is not pregnant who gets the flu. And much of that has to do with the respiratory system and the changes that happen during pregnancy. So we know from the studies that have been done so far that a pregnant woman who gets COVID is between 3 and 5 times more likely to end up hospitalized, on a ventilator, on heart-lung bypass, which is called ECMO, and deceased. And that's not something that I wish for any of my patients. And so that's one of the things that is really, really a driving factor of, okay, how can we protect some of our most vulnerable patients from getting this? Because pregnant women, just by virtue of the age range, are in the midst of their careers. They have to go out to take care of others, whether that is, children that they already have, ailing adults, what they do in the normal course of work. And so we really want to make sure that those patients get protected. The other thing that is a huge impact in COVID is that with COVID, we see increased blood clotting. And some blood clotting is not only normal, but essential for life, because you don't want to get a dinky paper cut and then 3 weeks later, you're still gushing fluid from the paper cut. You want the ability for your blood to clot to stop any, any cuts from bleeding or any injuries from bleeding. What we find with COVID is that COVID exacerbates that whole system. It makes people more likely to clot, even when they don't have a good reason to clot. So, for example, if you have if you have a surgery on your knee because you go skiing and you're from Arizona and you really have no good reason in your entire life to be on snow because it's the first time, and you then break your ACL or snap your ACL in two and you need a new ACL and so you get that surgery, you want your body to clot. And so when the surgeon goes in, they fix it, and then the blood clotting that your body naturally does stops that bleeding. Well, if you've got COVID, all of those factors may make that same kind of action in creating those blood clots without ever having an insult or a reason to make those. Now, you couple that with pregnancy, where pregnant women are more prone to blood clotting because that's a protective mechanism for the body. And when a woman is pregnant and giving birth, you have this giant watermelon coming out, and in the uterus, which is normally roughly the size of your fist, has expanded to be quite large. Well, the way that the uterus stops bleeding is it's coming down and really cinching down on those fibers. And you also have an increase in those blood clotting factors so that you can stop all of that bleeding. And so when you combine both pregnancy and COVID, all of a sudden you have scary levels of blood clotting that can be happening. And the worst of that is when those blood clots occur in the legs that then travel up to the lungs, or when they just start in the lungs. And that is a very scary aspect of COVID, because it is taking a normal event that happens in a non-pregnant person, which is then increased in a pregnant person and increases it even further. So people are at much higher risk of having blood clots that can be life-threatening for mom, for baby, or both. There's also a lot of long-term unknowns with COVID that we just haven't figured out yet. One thing that we know and that we are learning about is that there is a cytokine storm that happens when someone is approximately 10-ish days into a COVID infection. And what a cytokine storm is it means that the immune system is awake and really ticked off, and it's going to attack the invaders. Well, the problem is in COVID, those invaders are sitting in the lungs, so they attack the lung tissue and destroy it. They incite a huge immune reaction throughout the entire body. And so when you have someone who's got a higher, more active immune system, you end up with a more robust response. And the problem is that that can then be detrimental to the body. Instead of being protective, it's going into overdrive, and now you have a problem. And for women who are pregnant, they notice a decrease in immunology that then increases a little bit later in pregnancy. So, so it's more concerning when you see that and you've got this other infection going on that is known for stirring up all this immunologic impact. All right, so we've talked about COVID and pregnancy. We've talked about some of the things about COVID specifically that are more worrisome, more concerning in pregnancy. Next thing to talk about is, what are the vaccines and how do they work? Um, Vaccines are one of really the great marvels of modern medicine. They have made such a huge impact on mortality and morbidity, or the additional, not death that happens, but problems that arise from having a specific disease. They have made such a huge impact. It's part of the reason why people can easily live to 70, 80, 90 years of age. Um, the COVID vaccines have a couple of different mechanisms. Now, when I did this talk back in January, it was exclusively focused on Moderna and Pfizer vaccines, which are both mRNA vaccines. So we're going to talk about those first, and then we're going to talk about the new Johnson and Johnson one that's out. So with the Pfizer and Moderna vaccines, these are mRNA vaccines, and the technology is so just cool, amazing, fantastic, interesting, innovative. Like it's awesome. Because what they did is they took a tiny little snippet of that spike protein. So if you think about all the images of the COVID virus that you've seen, it's this ball with all these spikes coming out of it. They took that spike protein and they took the code for it. So what makes it look like a spike? And they took just a fragment of that and they put it into the vaccine that then gets injected. And so what the body does is the body picks up that material and says, oh, okay, we're going to make this now. And it pulls all of the little Legos that are in your immune system and are consisting of the proteins and everything that's got to come together. And so it takes all these little proteins and it makes a copy of the spike protein. And so that serves as a training mechanism for your body's immune system to say, oh, that's an invader, destroy, destroy, destroy. And what we have found is that when you take that little bit of protein, mRNA, and then convert it to protein, the body recognizes it. And then you get the second vaccine, and it's already been primed. So it already kind of knows this is a bad guy. I need to fight this. And so the second time it sees it, it just brings the whole gang, fights it, and knocks it down without the real virus coming anywhere close to you. This is a really important departure from how many traditional vaccines have been made. Traditionally, you would often find a weakened version of a live virus that was being injected. And so what that translates to is you can't give that to a pregnant woman. You know, there's a reason that several vaccines are administered to non-pregnant women only who are at least 1 to 3 months out from actively trying to conceive, because you want to make sure that even though it's a really weakened virus, she's got a healthy immune system, she's going to be fine, that it doesn't spill over into pregnancy at all. Well, the beautiful thing about these mRNA vaccines is that there's no live virus in there at all. So really all you're doing is giving the set of instructions, the body recognizes it, and it goes to town. So the reason that there's two vaccines, two different injections per vaccine to get immunity, is what I like to think of the kickboxing example. So when you go to a kickboxing class for the very first time, you sit there and you watch the instructor show you how to punch, how to kick, do whatever it is you're going to do that class. And so you might get up, be a little bit uncomfortable, whatever, but you're not going to feel a whole heck of it, a whole lot of it. That's very similar to that first vaccine dose. Yes, your arm is sore, but for most people, that's it. There's approximately 3.7% of people who have more of a reaction to that first shot. Well, the second one, that's the part of the kickboxing class where you are getting up and you are practicing and you are doing everything you can to just kick the snot out of that kickboxing bag. And so when you walk out of there, there's a much higher likelihood that you're going to feel that. You're going to be sore, you're going to be achy, it's going to be kind of blah. That's what the second shot is like. The first shot is the set of instructions. The second shot is practice. But what both of those things accomplish is that when you are out on the street afterwards and someone tries to mug you, you just take them down without even thinking about it. You might get a punch, you might get a kick or some bruises, but it's nothing compared to what would happen if you had never taken that class at all. So you're able to walk away from that mugging and be totally fine, maybe a bump or bruise here and there, but you're not going to land in the hospital in the intensive care unit, on, life support, on any of those things, because your body can deal with it. So that's how the mRNA vaccine works. It doesn't get encoded in your or your baby's DNA. mRNA tends to degrade really pretty quickly. The studies that we have seen so far, suggest that the likelihood of the actual vaccine actually reaching the uterus is very small, because it's going to be degraded well before it gets down there. And so we, as a vaccine for approaching this disease in this patient population of pregnant or soon to be pregnant women, it's really a beautiful, beautiful solution. Now, the next thing that people always ask is, well, what studies are there for safety of these new mRNA vaccines? Well, it's new because this is the first time it's been produced on a mass scale, but it's not necessarily new in that this technology has been around for a while. When SARS was coming out and they realized, well, we can't really treat SARS with the conventional vaccines, we have to come up with something else, they started to come up with all this mRNA technology. The problem with that is, or I should say, mRNA technology is applied to vaccine. mRNA technology has been around. The problem with all of this is that it's really expensive. And it's very, very expensive to develop a vaccine, have all of the science behind it that you need. It takes time and a crap ton of money to do a clinical trial. So it takes something like a worldwide pandemic to expedite all that. And it's very important to realize the difference between expedited and rushed. Expedited is when you walk into the busiest restaurant, fanciest, nicest steakhouse in town on Valentine's Day at 7 p.m. with your date with no reservation. And they see you and they look at you and they go, come right this way. Here's your table by the window with the view of the sunset, and your bottle of champagne is chilling. That's expedited. Rushed is how you made your bed when you were a teenager, when your mom told you that you had to clean your room before you could go out with your friends. Expedited and rushed are two very different things. This vaccine was expedited because the entire world was waiting for it. So it meant that the money was there. It meant that they didn't have to wait in line for all of the FDA attention that you need in order to get a new drug or a new vaccine or a new anything approved. It just went straight to the head of the line. It's the VIP pass at Disney, the nicest seat at the restaurant, the front row tickets at the favorite sold out rock concert. This was expedited. And so that's part of the reason why they were able to accomplish all this testing so quickly. The other part of the reason is that COVID was so prevalent throughout the entire world that it didn't take very long for them to get the study patients that they needed. Because any study you do, if you're looking at a really rare event that only happens in one in every 10,000 people or every 100,000 people, it's going to take a long time to figure out, just to find the people who have it, much less the people who got whatever drug you were giving them to make them feel better, to see if they did better. Well, when the entire world has COVID, you can give a vaccinated group and a non-vaccinated group all the study information and you follow them over a period of time. It's not going to take very long to realize that the people who are getting the vaccine aren't getting sick, and the people who aren't getting the vaccine are getting sick. And so that's how they were able to get 30,000 for one study, that was, I believe, Moderna, and 45,000 for the Pfizer study, like that. So there was no skimping on the numbers for the people who were done in these studies to show the effectiveness. And they show that the effectiveness was 94.5 and 95% for improving people's outcomes after getting COVID and avoiding them getting COVID completely. So that's the story on Pfizer and Moderna. Now, we also have Johnson and Johnson now, and that's a very new player on the scene. The technology for Johnson and Johnson has been around for longer, and it's a little bit more known and more tested. The way that the Johnson and Johnson vaccine works is that they take a little what's called a virus vector. And what this means is this is a totally innocuous virus, one that doesn't do diddly squat. And they take that little segment of code for that spike protein that I was talking about on the coronavirus. They take that little segment of code and they just boop, pop it in there. So now all of a sudden, you have a totally harmless virus with the little code that it needs to. They inject it in. That little code produces the protein, so the body now has a way to practice against it. Now, Johnson and Johnson is a one-shot deal versus the mRNA vaccines, which are two-shot deals. The effectiveness of Johnson and Johnson is in the mid 60s. It's like 66, 67%, somewhere in that range. But they have found that it is extremely effective for preventing severe disease. So you might get more of a mild case, but you're not going to get the case that's going to land you in the hospital, on the vent, on ECMO, or deceased. And so at this point, the recommendations for pregnant women, and this is universal, these sets of recommendations cross pretty much all the major regulatory bodies and scientific bodies that are important to me as an infertility doc, because I'm looking at the World Health Organization, I'm looking at the CDC and their specific immunization practices committee. I'm looking at ACOG, that's the American College of Obstetrician and Gynecologists, so the general OBGYNs. I'm looking at ASRM, that's the American Society of Reproductive Medicine. That is my educational society that I spend all my conference time on. There's also SMFM, that's the Society of Maternal Fetal Medicine Specialists. Those are the perinatologists who work with really high risk women. All of those groups have said, give pregnant women this vaccine. And that's when you get that many doctors to agree on something, it says something. Because normally, if you put 5 doctors in a room, you're going to get 6 opinions, and they're all going to be different. And so for there to be that many consensus statements from that many different bodies of physicians really says something. Now, people always want to know, what are the risks if I do this? The biggest risk of doing it is that you will not be the biggest risk of doing it is that there's the unknown. We are roughly a year and a half, a year, because we're in March now. I want to put us in the summer because I want to go swimming. But we're a year and a couple months into the development of this vaccine, because this vaccine started to be developed as soon as this became an issue in January, February. So before it hit the US. And that's a good amount of time. A ton of people have gotten the vaccine. We very rarely see a severe side effect from it or long-term effect from it, but we don't know ultimately what's going to happen. The flip side of that is that we do know many of the things that happen with COVID. And like I talked about a minute ago, with the blood clotting, with the respiratory, with the hyperimmune response, they're not good things to have happen, particularly when you are in the I'm going to get pregnant or I am pregnant phase, because 30% of women who have COVID in pregnancy have some really significantly negative outcome. Preterm birth, early rupture of membranes, some deficiency in the blood supply communication between mom and baby. Like, all of those things are bad news. And so when you look at the overall side effects, yes, we know that approximately 3.7% of people who get particularly the mRNA vaccine for their first shot are going to have some local irritation, fever, sore arm, cranky in general, fatigue, and that about 15% of people who get the second shot are going to have those symptoms. We haven't seen anything down the line that's really concerning. And there's been a lot of publicity about, oh my gosh, person had this and had the injection and got an anaphylactic response, or that X, Y, and Z thing happened. But what you have to realize is that in the overall numbers of people who have gotten this vaccine, and we're starting to hit in the 2 million, if not more, doses being given a day. The stories of the really terrible things happening get published because they're news. But what nobody is publishing is that, 1.989 million people got vaccinated today and nothing happened. And that's an important perspective because the bad events make news, the benign, whatever kind of events, that's not going to make the 6 o'clock news, the headline on the paper, or your news feed. Like it just isn't, it's not as interesting, so it doesn't get reported. The other thing to think about is timing of the vaccine. And so, in a perfect world, I would like to have everybody get their vaccine before they get pregnant. Now, that is becoming more and more of a likely reality as production is ramped up. The Johnson & Johnson vaccine has come into play, and the availability is more widespread. In a perfect world, I would love to have everybody vaccinated before they go through fertility treatment. That said, that's not necessarily an option for everyone, particularly when you've got people who don't have easy access to it, whose fertility treatment needs to happen right now for any number of reasons. And so, what we try and do is avoid having you get something that's going to cause a fever right around the time of an egg retrieval, right around the time of an embryo transfer. And I always give my patients the instructions, pay attention. And if you're getting a fever, if they do happen to have to get the vaccine around those times, then be really aggressive with managing it with Tylenol and ibuprofen to knock it down pretty quickly. And so that's been the main thing that we have been focusing on. And I've had many patients who have gotten pregnant and had the vaccine, during the course of their pregnancy, many patients who have gotten it during the course of their treatment. And that's something that I sit down with each patient when they say, hey, I've got a shot at the vaccine. What do I do? Do I take it? I cannot think of a single patient at this point I have had to say, no, you really shouldn't get it. I do have some patients where I have worked with them to manipulate the timing so that we're not doing anything to them at the same time they're getting the vaccine. A part of that is just making sure, yes, we can control that. So we might as well, the difference of a couple weeks is no big deal. So let's just make sure nobody's worried about it because as you guys all know, fertility treatment is a super stressful process. You really don't want one more thing to worry about. And so when I can work with patients to switch that timing around, I've been doing that. But all of this is not a substitute for sitting down with whomever your doc is and saying, okay, this is what I'm worried about. What do we do? And having that personalized discussion. But in general, it's something that is really a very helpful thing to do. It's protective for you as the parent. It's protective for your baby and some of the negative things that can happen during pregnancy if you do get COVID. And it's it's a phenomenal technology. I am so grateful and just pure gratitude. The day that I found out that these vaccines were approved, my eyes may or may not have been leaking because I was so grateful. As a healthcare provider and my family all in healthcare, at this point, everyone's vaccinated, and everyone got vaccinated really the second they got a shot at it. And the vast majority of physicians that I know who had a shot, especially in those early days where we didn't know as much about it as we do now, all the physicians who did know, who knew the science behind it, were running towards it. And it's something that's going to be very protective. So, okay. So that's kind of the big overview of COVID as it impacts pregnant ladies and women who are trying to get pregnant, timing, how all these things interwork together. There was a myth that I was seeing for a while going around the internet of it's going to make you infertile. No, it's not. And at this point, while there's no big studies that have come out on that, the vast majority of fertility doctors are like, yeah, my patients got their vaccines in December into January, and they've gotten transferred and they're doing just fine. The other thing is the logic of that makes absolutely no sense because they're saying that the spike protein is similar to a placental protein. And so if you've got antibodies to this, then you're going to make antibodies to that and it's going to prevent pregnancy. That's crap because if you have COVID, you're making the same, excuse me, you're making the same spike protein antibodies, and plenty of people with COVID have gotten pregnant without any issues after they have cleared the disease. So, so those are the big things that I wanted to touch on with you guys tonight. Do you have questions? Do you have thoughts? Do you have concerns? Do you have funny jokes? There's a little Q&A button down at the bottom, and that is one of the easiest things for me to track which questions I have and which ones I've answered. So do all of them recommend a COVID-19 vaccine or a specific one? I am assuming that that one and the question that just popped up of do you favor one vaccine over the others, those are very closely related. So do all of them, I'm assuming refers to the Moderna versus Pfizer versus Johnson and Johnson. And at this point, the initial recommendations were issued when just Moderna and Pfizer were out. The CDC has updated their site to include the Johnson and Johnson one. So the CDC is not distinguishing anything. The all the individual societies, I haven't seen if they have gone specifically to target the Johnson and Johnson one. But at this point, much of the feeling among physicians is get the vaccine you can. The Johnson and Johnson one, I don't worry about at all for women who are trying to get pregnant. I was doing some research beforehand to see, all right, like can I find anything more about the mechanism of this? Is there any way that putting this virus in the vector viral model would make a difference to a pregnant woman? I can't really see that it does. As an obstetrician by training, before doing all of my infertility fellowship work, I tend to favor whatever we have more information on, which at this point is Pfizer and Moderna. But frankly, I would much rather you get whatever vaccine you can. Whichever one someone is offering to you, for the most part, it's going to be yes, thank you, let's go for it. But I favor just a little bit more the Pfizer and Moderna just because we know a little bit more about it. Vaccine timing question. What is the known vaccine longevity? I'm planning to get vaccinated in April, embryo transfer in September. Will the vaccine still protect me in the fall and winter? Thank you. So yes, it should, because the people who got vaccinated last year in the trial are still showing immunity. So you should be fine. We still don't know yet if if this is going to turn into something like the flu vaccine, where they're just taking whatever variants are the most common and putting that out every year. But yes, if you get vaccinated in April, you should be good through September and beyond. All right, let's see. Let me keep going down. If timing is ideal, would you recommend after the retrieval, after the transfer, or once pregnant? If timing is ideal, I want you to get the vaccine the second someone will poke one into your arm. It's helpful to know where you are in the whole process. Like if you are if you're already in the midst of retrieval medications or transfer medications or whatever, that's something we're going to your doctor and saying, all right, this is where I am. This is when I can get the shot. Let's look at it. Makes sense. In a perfect world, I want you to get it before you do anything because I don't want you to get sick during a retrieval or a transfer because that's going to have a negative impact. And I am a little bit worried that as the world is opening up, there's going to be another surge that is going to be lower than what it has been because a lot of people are vaccinated, but it's still going to hit the people who are not yet vaccinated. So ideally, I want you to get it the second you can, but you can make a good argument for doing it before or in the midst of fertility treatment, depending on what your story is. I hope that that's a good answer for that. If you're towards the end of the first trimester, should you wait until the second trimester or any time? I would say beginning a second trimester, makes sense. There's no good data that says you are at higher risk if you do it in the first trimester versus a second trimester. There's some theoretical data that I can apply to say, all right, well, maybe we should have you do it in the second trimester. Um, One of the reasons people tell you to wait and to do anything, really, is waiting until the second trimester is because miscarriages are statistically more likely to happen in the first trimester. And nobody wants you to get a vaccine in this case, have a miscarriage, that the miscarriage was going to happen anyway. Vaccine had nothing to do with it. But all of a sudden, the vaccine's getting blamed for something that was inevitable and going to happen anyway. That's part of the reason why we tell you don't have sex, don't go to the gym, don't breathe funny until we see a heartbeat. Because we know as fertility specialists that miscarriages are most likely to happen in those first weeks. And it's got nothing to do with you. It's got nothing to do with me. It's got nothing to do with what you ate for lunch and or what you did afterwards or whether or not you had sex. But the last thing that we want is for you to have sex and then have a miscarriage and then spend the rest of your life thinking, oh my God, I caused this. The same thing applies to the vaccine. And so typically we have you wait until past heartbeat just to remove that psychological relationship. Um, you can argue that you should wait till the second trimester. You don't want any abnormalities in placentation, and the blood clotting really has a big impact on how the placenta implants and starts growing. So that you need to be good in the first trimester. So for my patients who are really high risk, I would say get it. For my nurses, for my doctors, for my essential workers, my people who cannot avoid people, whether that's in their own family or at their job or just out in the world, I tend to want to have you get it sooner. For people who are a high risk pregnancy, for normal pregnancies, that it's more of a, well, how are you a high risk pregnancy? If you have a ton of miscarriages, you may want to wait just so you don't blame the vaccine on it. If you do have a miscarriage. If you're high risk because you're diabetic and have high blood pressure, well, you may want to get it sooner because COVID hits those patients, pregnant or not, harder. Um, all right. So, for someone who's just had a retrieval, I would say give it a couple days, then go for it. Go through your mock cycle. You can run your mock cycle and your vaccine concurrently. So be fully vaccinated and then go into transfer. Um, okay, so asking because close to transfer date, the Johnson one, this patient can get 2 weeks prior, but the other are two, so would have to do the second less than a week before transfer. Talk with your doc about that and just go through what their preferences are. All three of us docs in our practice are weighing it by what do you do? What's your risk? Prior to transfer, I'm less worried about it because your fever is going to be resolved by then. Most people, if they have a fever, which is really and truly what I worry about, that tends to resolve within about 48 hours. So I'm less worried about that if you're a week out. But those are things that, touch base and talk to the coordinators, talk to, pardon me, talk to your doc and just see, all right, how do I work this? Because with all my patients who are in the midst of treatment, we've taken a look at it and say, all right, for you, let's do it here. Will getting the vaccine affect fertility? No, it shouldn't in either direction. It's not going to make you more fertile from anything that we know, and it's also not going to make you less fertile. What it can do is keep your overall health in good condition because those clotting effects that I talked about with COVID, the respiratory effects, people are still seeing them many weeks out after recovery. And so we want to make sure if you do get pregnant after having COVID, that you are far enough out. So if you can avoid getting COVID in the first place, so much the better. Let's see. How soon can you get vaccinated during pregnancy? We kind of talked about that. Usually pretty early on. For my high risk patients, I'm telling them the sooner the better. For other patients, we're telling them after 6 weeks. All those answers are right depending on your individual circumstance. Um, the So this next question, did you say I would not recommend doing a vaccine while pregnant? No, I didn't. I said I would recommend getting a vaccine while pregnant, because we want to get those antibodies on board as soon as possible to protect mom, to protect baby. There was a first recorded case of COVID antibodies in a baby's umbilical cord. I saw that note as well. The vaccine had been given a couple weeks before the baby's birth, so there was enough time for the mother to mount an immune response, which is really wonderful because now that baby is going to be even more protected. Also, if the mom's breastfeeding, there can be more antibodies that are passed. So I would say yes, do get the vaccine while pregnant. Um, and I think that's all of our questions. So I hope you guys have found this to be helpful. There's a lot of information. It's coming out. It's changing all the time. I did a search earlier today to try and get on top of everything that was as recent as I possibly could. But this is going to be rapidly changing as people get more and more data because everybody has their eyes on COVID and pregnancy and the vaccine and fertility and getting pregnant, being pregnant, all of those things. So well worth well worth staying on top of the news and keeping an eye on things, being very critical in how you think about what you're hearing, because sensational news is when somebody gets a vaccine and then 2 days later they have some big dramatic event. Well, just in the same way that getting hit by a car 2 days after a vaccine has no relation to getting your vaccine, many medical events have no relation to the fact that you've gotten your vaccine earlier. So they're going to be doing more and more studies. They're opening up vaccine trials to children who are 6 months of age and older. So those studies are coming very quickly. There have been some lab studies done on toxicity of the vaccine in lab animals, and everything has come up clean so far. So people are watching it. The data is going to be coming out more and more. So, all right. Well, y'all have a wonderful night. We will see you soon. Keep tuning in for the webinars for the information you want to get. And if you want to make an appointment, you can either reach out to our clinic or we will reach out to you to help facilitate all of that. And have a wonderful evening, guys. You take care. Bye.